Postpartum depression is a mental health condition after woman childbirth. Look at this. Mothers experience feeling of depression. Look at this. Signs and symptoms. A detail going on. Introduction. Postpartum depression is a serious mental health condition that affects women after childbirth. While it is normal for new mothers to experience mood swings or baby blues, PPD is more severe and persistent, potentially interfering with a mother's ability to care for her baby or herself. It can start soon after delivery or even months later, and if left untreated, it can have long lasting effects on the mother, child, and family. Definition. Postpartum depression is defined as a mood disorder that can occur in women affect childbirth, characterized by feeling of extreme sadness, anxiety, and exhaustion that may interfere with a woman's ability to function and care for her baby. Etymology. The term postpartum comes from Latin where post means after and partum means childbirth. The word depression originates from the Latin deprimer, meaning to press down, reflecting the lower mood and emotional state associated with the condition. Epidemiology. Postpartum depression affects approximately 10 to 20% of new mothers worldwide, with higher rates observed in low income or high stress environments. It typically develops within the first few weeks to months postpartum, but may occur up to a year after childbirth. Types. 1. Postpartum blues, mild mood disturbances, Usually resolves within 2 weeks postpartum. Not classified as psychiatric disorder. 2. Postpartum depression PPD, moderate to severe depression episode, typically begins with the first 4 to 6 weeks postpartum but can occur anytime in the first year. 3. Postpartum psychosis, rare but severe psychiatric emergency, involves hallucination, delusions, severe confusion. Onset is usually within the first 2 weeks postpartum. Causes: 1. Hormonal changes, drop in estrogen and progesterone. 2. Sleep deprivation. 3. Emotional stress. 4. Birth complications. 5. Poor social support. 6. Personal or family history of depression or other mental illness. Risk factors: 1. History of depression or anxiety. 2. Previous PPD. 3. Unplanned or unwanted pregnancy. 4. Lack of support from partner or family. 5. Stressful life events, example financial problems, marital issues. 6. Complications during delivery. 7. Teenage or advanced maternal age. 8. Substance abuse. Complications: 1. Poor mother-infant bonding. 2. Impaired infant development, emotional, social, cognitive. 3. Relationship problems. 4. Chronic depression. 5. Suicidal ideation or attempts. 6. Infanticide in extreme cases of postpartum psychosis. Pathophysiology, step by step pathophysiology of postpartum depression. 1. Sudden hormonal withdrawal. After childbirth, there is a rapid decline in reproductive hormones, estrogen and progesterone, which were elevated during pregnancy. This short hormonal shift affects neurotransmitter systems in the brain. 2. Neurotransmitter imbalance. The reduction in estrogen and progesterone alters the levels of key mood regulating neurotransmitters such as A. Serotonin, linked to mood and anxiety. B. Dopamine, linked to motivation and reward. C. Norepinephrine, linked to alertness and energy. These imbalances contribute to symptoms of depression, anxiety, fatigue, and emotional instability. 3. Hypothalamic pituitary adrenal axis dysregulation. Stress associated with childbirth, sleep deprivation, and caring for newborn activates the HBA axis. This leads to abnormal cortisol secretion, the stress hormone, which may worsen depressive symptoms. 4. Psychosocial and environmental stresses. Lack of social support, relationship problems, or financial stress intensify the mother's emotional strain. These factors interact with biological vulnerabilities to trigger or exacerbate TPD. 5. Impaired neuroplasticity. Chronic stress and hormonal changes can reduce brain derived neurotrophic factor BDNF, affecting neuronal health and mood regulation. 6. Genetic and epigenetic factors. A family history of depression or personal history of mood disorders increases susceptibility. Epigenetic changes during pregnancy and postpartum may influence gene expression related to mood regulation. This multi-step interplay of biological, psychological, and environmental factors underlies the development of postpartum depression. Signs and symptoms. 1. Persistent sadness or low mood. 2. Excessive crying. 3. Irritability or anger. 4. Loss of interest in previously enjoyed activities. 5. Fatigue or low energy. 6. Changes in appetite or sleep. 7. Feeling of worthlessness or guilt. 8. Difficulty bonding with the baby. 9. Anxiety or panic attacks. 10. Thoughts of harming self or baby in severe cases. Diagnosis. 1. Clinical interview and assessment. 2. Use of screening tools. A. Edinburgh postnatal depression scale. B. Patient health questionnaire. 3. Rule out other medical causes, example thyroid dysfunction. 4. Diagnosis is made based on DSM-5 criteria for major depressive episode within 4 weeks postpartum. Nursing diagnosis. 1. Risk for impaired parent infant attachment. 2. Ineffective coping related to postpartum changes. 3. Risk for self directed or other directed violence. 4. Sleep pattern disturbance related to emotional distress. 5. Altered self concept related to role transition. Medical management. 1. Pharmacotherapy. Antidepressants, example SSRI such as sertraline, fluoxetine. Hormone therapy, rare under specialist care. Antipsychotics in psychosis cases. 2. Psychotherapy, cognitive behavioral therapy CBT, interpersonal therapy IPT, group therapy. 3. Hospitalization in severe cases or if suicidal, infanticidal ideation is present. Nursing management. 1. Assess mood, affect, sleep, appetite, and suicidal ideations. 2. Encourage verbalization of feelings. 3. Educate about PPD and available treatments. 4. Promote bonding with the baby. 5. Ensure safe environment for mother and baby. 6. Encourage adequate rest and nutrition. 7. Facilitate family involvement and support. Treatment options. 1. Pharmacological treatment. A. SSRIs, example fluoxetine, sertraline, paroxetine. B. SNRIs, example venlafaxine. C. Raxinolone, FDA approved for PPD. 2. Non-pharmacological. A. Psychotherapy. B. Support groups. C. Exercise and lifestyle changes. 3. Electroconvulsive therapy ECT for severe treatment resistant cases. Psychosocial medicine. 1. Support groups, peer led or professionally guided groups provide emotional support and reduce feeling of isolation. 2. Mother infant bonding programs encourage physical touch, breastfeeding support, and responsive parenting. 3. Cognitive behavioral therapy helps Mothers challenge negative thoughts and develop coping strategies. 4. Family therapy involves partners or family members to improve communication and support systems. 5. Community health nursing visits, home visit for counseling, screening, and follow up care. Prevention 1. Antenatal screening for mental health risk. 2. Prenatal education about normal postpartum changes. 3. Early postpartum follow up care. 4. Strengthening social support systems. 5. Lifestyle modifications, regular sleep, exercise, and healthy diet. 6. Counseling for at risk mothers during pregnancy and after delivery. In conclusion, postpartum depression is a common but serious condition that can have profound consequences for both in the mothers and her child. If left untreated with early identification, appropriate treatment, and supportive care, most women can recover fully and regain their well being. Nurses, doctors, families, and communities all play vital roles in recognizing, managing, and preventing PPD, thereby promoting healthier beginnings and hopeful futures for mothers and their children. Thank you. Have a nice day.